I'm Faraz Pathan. I'm a cardiologist and clinician scientist. I'm the director of heart research at Nepean Hospital, and my research mainly focuses on predicting and preventing cardiovascular disease.
And I'm Georgia. I'm currently a resident specialty trainee in obstetrics and gynecology in London. And my research interests are primarily benign gynecological diseases, which include endometriosis and PCOS.
I'm Matthew Leonardi, a gynecologic surgeon and sonologist at McMaster University in Hamilton, Canada. And I was once a PhD student at the University of Sydney, where I had the fortune to meet Dr. Faraz Pathan. And a lot of this work began in a hospital corridor conversation type fashion. Really interesting origin for this gynecologist and a cardiologist meeting. Essentially, after a Nepean research day, Faraz came up to me and inquired about endometriosis and the risk of endometriosis on cardiovascular diseases, which is what he sees in his day-to-day clinical and academic practice. And at that time, as a junior academic, I knew very little about this, but I thought this is a very interesting question to ask because we know endometriosis is a systemic inflammatory disease. So back in 2019, this all kicked off, and together we established a very large team across the world, international representation from North America, Europe, and Australasia, and have successfully put together a fantastic research paper that has just been published in the Heart British Medical Journal. And Georgia, as the lead author on this study, tell us, what is the name of the paper? What's our manuscript called? And tell us what the study design is.
So the name of our paper is Non-Malignant Gynecological Disease and the Risk of Cardiovascular and Cerebrovascular Disease, a Systematic Review Meta-Analysis. So the type of study that we've done is in the title, so Systematic Review Meta-Analysis. And what this means is that we looked at research that's already been published. So we searched various databases and combed through lots of different studies to find data that's already been published on our outcomes of interest. And then we extracted the data from these papers and we combined all of these numbers to come up with our own overall estimate. And this is actually considered one of the highest forms of evidence that we can have. Obviously, we have to consider other things like the structure and the quality of the studies that we took our data from. But yes, that's how we conducted our study.
Throughout this conversation today, we are using the terminology women, as this is what the studies have assessed, individuals who are assigned female at birth and generally speaking in these studies exist in the world as cisgender female. However, we do have to note that individuals who are transgender male or gender diverse individuals may also be at risk if they have these non-malignant gynae disorders as well. So this is just something that we have to keep in mind throughout this entire discussion for application to all people that can have these gynecologic concerns. Can you tell us a little bit about which non-malignant gynecologic diseases came out of the research that's been done and what we were able to extract?
So originally we set out with the intention to extract data on all non-malignant gynecological diseases. However, obviously we're limited by what we can find that's been published in the current research. So what we ended up with is mainly endometriosis and PCOS. And we also have a couple of studies that look at irregular periods and painful periods, or the medical term for this is dysmenorrhea. With these last two, we kind of consider them almost a proxy for endometriosis in the case of painful periods and PCOS in the case of irregular periods. So those were the two main gynecological diseases that we did focus on.
And on the other end of the spectrum, which cardiovascular and cerebrovascular diseases were included in our study?
So our overall outcome, our primary outcome, is combined risk of cardiovascular and cerebrovascular disease. And that included endpoints that combined all different cardiovascular diseases and cerebrovascular diseases together. So that included ischemic heart disease, peripheral vascular disease, cerebrovascular disease, and within ischemic heart disease, subtypes of that, and any different definitions that the studies may have had. In terms of our own subgroup analysis, when we did break it down, we broke it down into ischemic heart disease and cerebrovascular disease.
Faraz, how did we feel about that? Are these the most relevant cardiovascular and cerebrovascular disease issues that are faced by your patients?
Absolutely, Matthew. Cardiovascular disease is responsible, and cerebrovascular disease combined is the cause of 1 in 3 of us eventually passing away. It is that prevalent. What I love about the methodology used here is it's informed by hard endpoints. It is clear cardiovascular disease and ischemic heart disease, cerebrovascular disease, rather than soft endpoints where you can get inflammatory markers and other things, meaning that this data is robust. It reflects outcomes patients care about, not what we care about as academics or scientists about, certain blood tests being abnormal, but patients care about the fact, am I going to get a heart attack? Am I going to have a stroke? So I think this data reflects the concerns of the community. It then empowers me to use the tools that I have. So I'm excited. I'm excited by the fact that we actually had positive findings using hard endpoints, which is a much higher bar. It does mean that the amount of studies you have is limited because it is a much harder task to run these kind of studies. But I think that is a testament to the analysis, that the strength of it is what you exclude.
Although
Absolutely.
saying that the studies are limited, in reality, we ended up with quite a large number of studies, 28 studies, and that incorporated over 3 million individuals across both the exposure and the control group. So we actually ended up with quite a good number in the end.
That you couldn't run a study of 3 million people, and that's the power of a meta-analysis, is you can running a study on 3 million people is next to impossible. It is massively cost prohibitive, and my mind would explode in terms of the budgeting I'd need to do to get a grant for that. So to be able to do this and to get yes, there's a heterogeneity between the studies, but consistent signals is really exciting.
Absolutely.
So we've referenced the positive results. I mean, positive is a sort of loaded term in the context of medicine and in terms of research. Maybe not positive in that this is good news. It's probably not good news for patients with these non-malignant gynecologic disorders. Giorgia, tell us what the results were. Can you break it down for us?
So our overall primary outcome was the association of non-malignant gynecological diseases. So that incorporated all of the diseases that we looked at, and the risk of cardio and cerebrovascular disease. And we actually found a 28% increase relative to people that don't have these non-malignant gynecological diseases. Then when we broke it down for the same composite endpoint of both cardio and cerebrovascular disease, but for PCOS, the risk remained elevated at 28%, so the same as our overall increased risk. And for endometriosis, it was 30%. So the results were quite consistent in both subgroups of the gynecological conditions. Now, when we looked at the non-malignant gynecological diseases together, the risk still remained elevated when we looked at ischemic heart disease. It was a 41% increase. And within ischemic heart disease, we did break it down even further. For PCOS, it was 42%, and for endometriosis, 36% increase in the relative risk. For cerebrovascular disease, the overall risk for all gynecological diseases was a 33% increased risk. And for PCOS, it was a 47% increased risk. So that's actually quite significant. Whereas for endo, it was a 24% increased risk. As we said, this is over 28 studies with over 3 million individuals. But we do have to keep in mind that these numbers are relative risk, not absolute risk. So compared to the general population risk in the background.
Faraz, can you enlighten us a little bit around, people walking around the world? What is that baseline risk just in society? And obviously, there's lots of reasons: environmental, genetics, other diseases. How do we contextualize this result to help people understand the true risk that they might be having with endometriosis or PCOS?
That's a tough question, Matthew, but let's break it down. So we currently use risk calculators, and we tend to divide groups into a more than 10% risk, a 5 to 10% risk, less than 5%, and then less than 1%. if someone comes to my clinic room, I use the Australian Cardiovascular Disease Calculator, but there exists a European one and an American one as well. And currently, that's informed by your age, by your diabetes status, so whether you have diabetes or not. And that's important because insulin resistance significantly overlaps with polycystic ovarian syndrome, but also your cholesterol level, your high blood pressure, and I think the other intangible risk factor is your family history. Absent from, so it would be the condensation of all of this risk. Now, obviously, in a systematic review, you get zoomed out data, not necessarily very granular data, but what this suggests is that there is additive risk at the very least. We don't know if it's multiplicative. That's something I think we as a group have to investigate. That if you have these disorders, and the relative risk of 40%, well, depends, at what age that is relevant. Because in someone who's 18-year-old, that may not be as big a deal as it is in someone who's 40-year-old. The other thing that was difficult to tease out here is severity. Right? If you have severe endometriosis or if you have very mild endometriosis, is the effect size sustained or is this a dose-dependent relationship? Similar situation with polycystic ovarian syndrome. So I think what we have here is a signal that we cannot be ignoring these risk factors. How this matters for me as a clinician, it should matter to primary prevention physicians such as general practitioners, would be that when we see someone who is who may have had endometriosis or polycystic ovarian syndrome, we actually ask about that. And current practices at the moment, beyond these calibrated tools, you can use enrichment risk factors. So enrichment risk factors in Australia, for instance, actually include the postcode which you live in, because social determinants of health are very, very important. And at the moment in my practice, I would use this as an enrichment risk factor. So if my calculator is saying that this 40-year-old sitting across from me with high cholesterol has intermediate risk, I may, based on a long history of endometriosis, reclassify her as high risk. And that changes a few things for me. That changes the timeline, that changes the intensity of the investigation, but it also changes the goalposts of how low I want that cholesterol to be, informed by a history of endometriosis or by polycystic ovarian syndrome. I think from the data we have, that would be a reasonable approach to take, with all its limitations. And what we need to do is in some ways reinterpret the findings to look at cardiovascular disease in women, to look for risk factors that are specific to women, which may be different to those from men.
My next question is for you, Giorgia. I want to try and understand a little bit about how we can connect these two issues, the non-malignant gynecologic disorders and the cardiovascular and the cerebrovascular disorders. Are we talking about a confounding effect, a mediation effect, or a causality? And can you tell us what these types of terms mean as well?
So in our study, we have to be careful not to overinterpret the results. So we've not been able to establish causality in this study. However, that's what this association that we're investigating would be. Causality indicates that the non-malignant gynecological diseases are causing the cardiovascular and cerebrovascular diseases, and underlying biological mechanisms that may associate these include something that Faraz mentioned earlier, actually, which is chronic low-grade inflammation, which has been proven to initiate atherosclerosis, which leads to cerebrovascular and cardiovascular disease, and has been shown to be present in people with endometriosis and PCOS. The female hormonal environment also plays a role. We do know that while a lot of studies look at men's risk of cardiovascular disease, women or individuals of the female sex tend to have a similar incidence of cardiovascular disease once they reach the perimenopausal period, and the protective effects of estrogen decline from there. So we do know that there is some role for the female hormones, and we do need to investigate that further. One thing to be careful of is the confounding factors, especially in a disease like PCOS, which has a strong association with metabolic syndrome, which can be a confounder for cardiovascular and cerebrovascular disease. And in fact, we kept this in mind in our analysis. And we did do a sensitivity analysis, subgroup analysis that looked at studies that did adjust for these factors, such as BMI, blood pressure, hypertension, classic modifiable cardiac risk factors, and the association was still maintained. So that is a sort of a point towards this association being causal rather than just a confounding factor for cardiovascular disease.
And what about the mediators? So things such as the treatment options that patients with endometriosis and PCOS use, whether those are medications or surgical. A lot of patients with these diseases undergo removal of their uterus, sometimes removal of their ovaries, or at least endometrioma is part of the ovary, which can lower somebody's ovarian reserve. Is this potentially playing a role?
We said absolutely, the mediators are important. So the treatments for endometriosis and PCOS were an important consideration, although not all studies reported this. One study in particular did look at this and actually did an analysis of the patients with endometriosis that had undergone surgery to remove the uterus and both tubes and ovaries. This was a study performed by Mu et al. In 2016. And they did find that in patients with endometriosis that had this big surgery, their risk of cerebrovascular disease was elevated. So there is potentially a role of these mediators of, the hormonal treatments we give to patients with these conditions and the surgeries that they undergo, which could play a role. But this definitely needs some more investigation.
Mm-hmm. It sounds to me like these gynecologic diseases and even just cardiovascular, cerebrovascular diseases, the risk factors in women, in individuals assigned female at birth, is a black box. We really don't know very much at all. So where do you think we got to go next in terms of this particular research question, understanding the correlation, the causality between the non-malignant gynae disorders and the cardiovascular and cerebrovascular ones? Maybe Giorgia can answer that first.
I think that no researcher will ever tell you that there is enough research. So I think a classic thing that we will say is that we do need more research. We need some high quality studies that also especially consider confounding factors. As we said, that's quite important when considering everything, but especially PCOS. And obviously, the more data we have, the more research we have, the more high quality studies that consider also the temporality. So ensuring that the non-malignant gynecological disease was diagnosed prior to the cardiovascular disease. This will help us establish a tangible link between these conditions with robust evidence that can help us prove a sort of causality. Subgroups as well, including sort of the severity of the disease. As Faraz said, does the severity of the condition have a dose-dependent effect on the risk of cardiovascular disease? And further to that, investigating sort of the underlying mechanism of this association. Why is it that these conditions are associated?
And what I know as a gynecologist is that most of my patients with endometriosis don't just have endometriosis. Many of them have concurrent adenomyosis. They have concurrent fibroids, polyps. They have PCOS, many of them. And so is there also an additive effect if you have multiple non-malignant gynae disorders that can impact on your future health? Is the severity of this disease of endo or PCOS, although PCOS doesn't have quite as much of a spectrum, let's say, as endo is known to have, how impactful is that in their future? So many interesting questions.
Endo has also been shown to be associated with autoimmune conditions. That could be another interesting angle to investigate and understand the impact of those on markers like cardiovascular and cerebrovascular disease.
Yes, absolutely. Faraz, what thoughts do you have on what the future holds?
I have probably two thoughts, Matthew. One is as a clinical cardiologist seeing patients in my clinic on Thursday and Friday, and then as an academic. First thing is rubber hitting the road. We know we get all this data, and remember, we're doing a systematic review of existing data, but it was data I was ignorant of. So the first thing is that we will have patients in front of us that ask us to integrate the best available evidence and to manage them. And I to a simple question, what would I do if this was my mom or my sister? And from what we've found, what I'm going to do is look at these disorders as at increasing your cardiovascular risk. To the extent I don't know. And we have to explore that. We have to be honest with our patients. But it would mean if I see someone at low risk, I'm going to double down on prevention strategies to say, well, look, you're not entirely low risk. There is something here that may increase your future risk of heart disease. If I'm looking at someone intermediate or high risk, I'm going to focus more on prevention, but also potentially having more tighter targets for my modifiable risk factors, whether that be blood pressure or cholesterol, and engaging with the patient in a more assertive manner because we are talking about a higher risk. That's in the short term. In the long term, I'm going to echo Georgia's comments. I do think we need more research. If you look at the vast majority of long-term cohort cardiovascular studies, the most famous one being Framingham, that looked at a predominantly male population, a predominantly Caucasian population. I don't think it reflects the diversity of practice we see in terms of diversity of gender, of culturally and linguistically diverse groups. I think if we're going to heed what we already know, we need to reinvent some of these long-term cohort studies and to follow up large populations to incorporate these additional risk factors, but not just benign gynecological risk factors. You alluded to the fact that environment is a risk. We have a heating planet. We have far more pollution. And we don't know what effect these are going to have. What I can tell you in my practice, working in a region which has a high burden of cardiovascular diseases, our patients are getting much younger. We are seeing patients who don't always have the standard risk factors. This is a conundrum we're dealing with as cardiologists, and what this tells us is there are unmapped risk factors, some of which may well be benign gynecological risk factors, that need to be investigated. And this requires, I would say, a level of investment from governments that are interested in their population and their voter base, which is far more diverse than it may have been historically.
Yes, absolutely. And I'm thinking about this as well from my perspective. I'm looking after patients who are usually around 18 years of age until their menopausal age range, 50 or so. And I kind of brush off the vital signs when people come to my clinic, what their blood pressure is, because it's not what I'm trying to treat them for, but maybe it's something that us gynecologists need to start paying attention to in those that are maybe late 30s, early 40s. Those that have endometriosis, maybe they have some higher BMI factors as well. This is something that maybe I need to pay more attention to. Can you give me a little bit of advice as how might I convince my local cardiologists to care at this point? If I want to send referrals to them for primary prevention, or maybe it's not the cardiologist I need to convince, maybe it's the primary care providers, but how do I start to have that conversation with those people who are in the role of taking care of the cardio part of the story?
Well, look, I'm optimistic that by publishing in Heart Open with Georgia and yourself leading it, it starts a conversation. I think there's an onus of us on researchers not just to pat ourselves on the back when the paper is published, but to communicate this to the relevant stakeholders. That may be patients, but also it is the relevant societies. So, something such as this should be communicated to the Cardiac Society, say in Australia, or the British Society as well, and in Canada. To say, guys, this is something that we need to be cognizant of. On a day-to-day, I think that the best change happens locally, is organizing a meeting within the educational calendar where you have, at a large hospital, you have thought leaders. And if you can present this data to them, take the punches and actually, because often those punches are very relevant research ideas for the future, to make them aware, because again, I put my hand up when I had this conversation with you in late 19, early 20, I was ignorant of these. So I think, except that we will have blind spots. And it's our job as academics, not just to publish, but then to eliminate those blind spots. The thing you hit on, Matthew, that was super important, though, we talk about causality, and that's very difficult to establish, but we have associations. And let's take the example of endometriosis. The most plausible one is low-grade chronic inflammation, but endometriosis also causes a lot of pain. How does that pain impact someone's healthy life behaviors or their food choices? Because that's going to be a confounder that hasn't been captured in each of these studies. And the third confounder that I often experience is, the boxing analogy, the punch that knocks you out is the one that you don't see coming. If you have someone with significant endometriosis, their primary relationship from a healthcare perspective may be with their gynecologist. They may not be seeing their GP as often. And when they do see their GP, they will be talking about their gynecological issues. So I think the other issue is within our existing almost siloed models of care, there is an opportunity to do prevention for every single physician, whether you're a gynecologist, a dentist, a general practitioner. And prevention early on is usually simple. It doesn't involve pharmacotherapy because these patients, whenever they see their GP, they're talking about their endometriosis. When they see you, they're talking about their endometriosis, and their risk factors, there may be a 5 to 6 year lag time before they're acted on. And I think these are the associations, whether they're mechanistic biological underpinnings, such as inflammation, whether they are behavioral underpinnings, because we know that chronic pain in any form impacts your health-related behaviors, or they're almost economic underpinnings, which is opportunity cost of not who you're not seeing, what you're not talking about, or the opportunity cost in some health services of the cost of seeing a provider. You may not always want to see someone else for standard care. That's what we need to unpack. That's what we need to unpack as a group. And I think that's the next exciting frontier.
Yeah, I totally agree. And it brings me to a couple final thoughts on this regard. The first is that there is a growing recognition that at least endometriosis, one of the two main non-malignant gynecologic diseases that we studied here, is more than just a gynecologic disease. It is truly a systemic, chronic inflammatory disease that has relevance across all disciplines of healthcare and probably does need to be more of a focus of primary healthcare than it is currently specialty healthcare in the hands of a gynecologist. And that's why my team has introduced extensive interdisciplinary care efforts for our patients, working with registered dietitians, working with psychologists who have expertise in pain and that relationship between stress and the body's experience and vice versa. We also have a huge integration of physical therapy, often delivered by pelvic floor physiotherapists. And those are just a few examples of how we're trying to address this disease beyond the traditional scope of gynecologic medications or surgery. And hopefully that recognition of endometriosis beyond the gynecologic needs is growing. I know it is in my institution, and I know it is in Nepean for sure, across the globe. The second is you're totally right that some of these gynecologic diseases, endometriosis, become quite a focus. And there is almost an identity around it where that becomes the main thing that a person with endometriosis deals with over the course of many, many years, generally speaking, their young adulthood and then beyond into perimenopause and menopause. And what unfortunately happens is that a lot of other concurrent things are blamed on endometriosis or blamed on PCOS. And people forget that this is a human who has other elements to them. I hear this from my patients all the time. They go to the emergency department, they go to their primary care provider, and everything is endo. That symptom, that's endo. Maybe we need to stop blaming endometriosis in a more direct way and start to think again outside the box, but also maybe blaming endometriosis for some of the other things that could be happening in people's lives. So it's a little bit of maybe a double-edged sword there. Endo is relevant. We don't want to focus on it entirely, but we do want to make sure it is a focus. And I think we're at a point in time where this conversation is happening across disciplines. It's happening in the media, and patients are so smart. They're advocates for themselves. So I certainly have a lot of optimism for healthcare, quality of life improvements in these non-malignant gynae diseases. And I think this study will help contribute to that.